Welcome to this presentation from Myopia Profile on optical interventions in myopia management. This is part of a series of presentations for Myopia Action Month aimed at helping eye care practitioners understand and communicate the key messages of myopia management. My name is Brian Peng and I'm a professional content developer for Myopia Profile with a background as a clinical optometrist. Today, we're going to take a focused look at ocular interventions in myopia management, specifically the optical treatments that are showing the strongest evidence and the best outcomes of 2025. We'll walk through 1. Why optical treatments are a first-line approach to myopia management, 2. The strongest performing interventions right now, 3. Your options across spectacle lenses, soft contact lenses, and ortho-k, and 4. How to make practical prescribing choices in clinic. Okay, so why prescribe optical treatments? Optical treatments are a great first-line intervention for many reasons. The most prominent advantage of an optical approach is convenience. Since myopic children require vision correction, optical interventions make the most sense, as they offer the dual benefit of myopia correction and myopia control. Importantly, we have a large and growing body of evidence showing that optical designs can meaningfully slow eye growth and not just correct the vision. Now let's not overlook the everyday advantages either. Optical treatments are well accepted and tolerated, low risk, and can be tailored to various lifestyles, making them really suitable for children. They're familiar and easy for families to understand and often easier for us to prescribe and monitor. So for many children, these become the backbone of our myopia management plan. Next, what are the best optical treatments to prescribe these days? If you're unsure where to start, the free-to-download Managing Myopia Guidelines infographic provides a really neat summary of treatment options, broadly categorized by efficacy. Now let's define what we mean by best. We're looking for treatments that have at least 12 months of published randomized controlled trial data and also reduce axial elongation by at least 50%. Now this does narrow it down to a handful of interventions that consistently outperform single vision lenses and also give us predictable outcomes over time. Now, interestingly, many of these designs share some key features across both specs and contacts. These include a clear central optical zone, a single vision background, treatment zones arranged in a pattern around the optic zone, and they also avoid disrupting binocular vision or accommodation, which really helps to maintain comfortable wear across the day. And now, years of research and development have led us to the point where numerous commercial designs for myopia management are now available. And these cover modalities from glasses to soft contact lenses and to ortho-k as well. Just note, some of these products are limited to certain regions due to regulatory barriers and scope of practice. Now on this slide we have 4 main contenders: Stellest, MyoSmart, DOT, and MyoCare designs. The data behind these is pretty compelling. The 12-month results suggest that Stellest, MyoSmart, and DOT have similar treatment effects, slowing axial elongation by at least half. These results are clinically meaningful, especially over the long term, as each of these 3 designs have multi-year data backing them. While MyoCare is close to that 50% benchmark, the data is relatively new. Next, we'll highlight the features among the spectacle designs with high efficacy and long-term data. Now, each optical design for myopia control handles the treatment zone a little bit differently, as we'll see very soon. Essilor Stellest lenses use highly aspherical lenslet target technology. Here, the treatment zone consists of 11 concentric rings of highly aspherical lenslets to create a volume of myopic defocus. Next, Hoya MyoSmart spectacle lenses are based on the DIMS design, which refers to defocus incorporated multiple segments. And the MyoSmart lens applies a honeycomb array of plus 350 diopter lenslet segments to introduce consistent myopic defocus across all distances. The DOT spectacle lenses incorporate diffusion optics technology and use a different theory of myopia control. Unlike the other designs, DOT doesn't use lens segments to create defocus. Rather, thousands of microdots modulate contrast, aiming to reduce the visual cues that drive axial growth. Contact lenses are great for kids as the outcomes of myopia control can be comparable to spectacle lenses, but with some added benefits of lifestyle flexibility and easier compliance with full-time wear. Leading the comparison is MySight 1-Day, with the longest running soft contact lens study among children, and has proven itself with really strong short-term outcomes and sustained efficacy over 7 years of follow-up. Menicon Bloom Day, also known as Natural View Multifocal 1-Day, has demonstrated excellent 12-month efficacy, but outcomes for longer durations haven't been published yet. Similarly, Seed 1-Day Pure EDOF or Milo lenses have shown very respectable short-term efficacy, 2 years of RCT data and 4 years of prospective trial data. On top of this, 2-year results have just been released for Milo toric lenses, which is the only toric option on this list. MySight 1-Day is one of the most widely prescribed interventions for myopia control at the moment, so we're going to go in a little bit more detail. There are 2 distinct optical zones in the MySight lens, giving it dual focus properties. There are 2 vision correction zones for correcting myopia. These alternate with 2 other treatment zones which each produce 2 diopters of defocus to slow eye elongation and myopia progression. Now, where does ortho-k fit in all of this? While ortho-k isn't new, its role in myopia control is well documented. Over the years, ortho-k has been perceived as one of the most effective myopia control options worldwide. Ortho-k lenses are an ideal choice for myopia management with a strong evidence base. Meta-analyses show that ortho-k reduces eye growth by around 45%, and long-term data up to 10 years confirms safety and sustained benefit over time. The original premise of ortho-k lenses was for refractive correction. By wearing ortho-k overnight, the central cornea would be flattened, reducing its power and reducing the myopia in turn. However, the geometry of these ortho-k lenses creates a corneal profile that produces myopic defocus, the same optical signal which is said to slow eye growth. Previous studies have also suggested that higher baseline myopia can be associated with greater myopia control in ortho-k wearers. Now, this doesn't mean that ortho-k is any less effective for lower myopes, but that ortho-k may generate larger treatment effects in those with higher myopia. Up until this year, ortho-k was also the only treatment which was shown to be effective for slowing progression in the more myopic eye of patients with anisometropia. So, what should we take away from all this? Prescribe based on what you have available and what best suits the child's lifestyle, family, and motivation. Prioritize treatments backed by strong clinical evidence. There are a lot of effective treatments out there, but those with long-term safety and efficacy data will add extra confidence to your prescribing decisions. Finally, ensure full-time wear, no matter what the modality. Remember, the medicine doesn't work if the patient doesn't take it. For more information about myopia control products, just head to the Myopia Control Product Compendium on our website. It's our platform for keeping you updated about the latest developments in myopia tech and research. Thanks for tuning into this lecture, and good luck in practice.